for being here. My name is Aaron Bloom. I am the CEO of DocMJ. My background is law. I am an attorney. And I will tell you, I spent many, many years attending and speaking at lawyer conferences. Lawyers like to talk about how hard they work, how many hours they work, how many hours they build. However, if I said to them, hey, I moderated a panel for doctors, it started on Sunday at 10:30, and it was 2 hours, and none of them would believe me. So that's a long way of saying, congratulations for giving us your weekend and being here and learning and being interested in this very important topic for your patients and for Florida. So we'll get started. We've got a great panel up here talking about the business of cannabis, which is evolving every day, and whatever we say today, we'll probably say something different next year as this industry changes so quickly. I'll let our panel here will introduce themselves when they come up, and we'll start with Dr. Hershfield.
Thank you, Aaron. Hey, everyone. Thanks for sticking it out till the end. I'm Barton Hershfield. I have a solo medical cannabis practice in Southwest Florida. There we go. All right. I do not have any products or services to try to sell you. However, I do hope to sell you on the concept that tracking outcomes can help your patients and your practice. We're going to talk about why we should consider tracking outcomes, which outcomes to consider tracking, how to track them. We'll go through a couple patient case studies to show how tracking individual patient outcomes can help you help your patients. And we'll close with talking about how tracking cumulative data can help your practice. What we need to ask ourselves is, what is the goal of the medical cannabis certification visit? Are we simply gatekeepers accepting people's money in exchange for access to the medical marijuana highway, pun intended? Or are we compassionate healthcare providers who really strive to educate our patients and to work with them to give them specific recommendations to help them get the best relief with the least side effects? Hopefully it's the latter, and by the virtue of the fact that you all are at this conference and those listening through Zoom, I feel much more confident that more of our physicians and practices are really doing this for the right reason. That's to help the patient. But you can imagine for a patient, especially a new patient, trying to decide what product to try can be intimidating, if not completely overwhelming. Do I use a sativa? Do I use a hybrid, an indica, a ratio product? And then how do I take it? As a capsule, sublingual, edible, topical, vape, flower? And then what? It's not all about the THC. There's other cannabinoids that I should be concerned about, CBD, CBG, CBN. And what? On top of that, there's terpenes. And as we all know, those of us who work with cannabinoids, one size does not fit all. One type of product that works great for one person with a particular symptom may not work very well at all for another person with the same symptom, yet another product may work great for them. So what this all means is patients really need us. They need us to educate them. They need us to give them recommendations on types of products to try, not only the first time that we see them, but when we see them in follow-up to give them adjusted recommendations based on their current response to their treatment regimen. So how do we assess response to treatment? Well, two basic ways. One is qualitative. That's basically a yes, no. Are you improved with treatment? And the other is quantitative. How much improvement are you getting with your current treatment? Which is more helpful in guiding treatment? Let's use treating hypertension as an example. Meet Bob. Bob has a blood pressure machine at home. He monitors his blood pressure regularly. And he noticed that it's gone up to 186 over 116. So he contacts his primary care provider and starts him on an antihypertensive. Because Bob monitors his blood pressure, the provider is willing to do a follow-up telehealth. Now, if the provider was going to assess Bob qualitatively, he would ask Bob, is your blood pressure lower? Bob replies, yes. Does that mean there's no need to adjust Bob's treatment? But if the provider asked a quantitative question, what is your blood pressure reading now on treatment? Bob replies 152 over 100. Well, is it better? Yes. But is it adequate? Well, of course not. So the provider adjusts Bob's antihypertensive, and now when he sees them again at another follow-up telehealth visit, he knows to ask Bob, now what is your blood pressure reading? Bob says 120 over 76, so it's obvious that now Bob is obtaining optimal and adequate treatment benefit, and there's no need to change his medication. So that's how we adjust hypertensives. How do we adjust other medicines? Well, with statins, we measure the lipids. With insulins, we measure the A1C and glucose. With thyroid hormone, we measure the TSH. So how do we measure the response to medical cannabis? By measuring symptom reduction. And how do we measure symptom reduction? It's not rocket science. It's not unique. We just employ, that 10-point severity scale where 0 is no symptom, 10 is the worst. We're all familiar with this system for pain management on a pain scale, but this can be applied to any symptom. What number do you give your anxiety? What number do you give your insomnia? Whatever symptom you're measuring. So when we first see a patient, we write down what symptom they're being treated for. We ask them to rate their symptom on a 10-point scale without cannabis. And then if they are using cannabis, whether it be a transfer patient who's already in the system, they're using medical cannabis, or whether it be an initial certification and they're using legacy cannabis products, we ask them what their symptoms are when they're using the cannabis. Then, at their recertification visit, we ask them again. We already know the symptom, and we already know the severity without cannabis, but we ask them, what is the severity of your symptom with the regimen you're using now? And, we have a space on the chart just to prompt us and make it easier to find, but you can certainly simply, in a free text note, write, patient has X symptom, it's rated an 8, without cannabis and a 4 with cannabis. So let's show how this would work with just 2 patient studies. Meet Jennifer. We see Jennifer because of anxiety, which she rates as an 8 out of 10 in severity, and she's not tried any cannabis products. So at her follow-up visit, if we were using a qualitative question, we might ask Jennifer, is your insomnia better? She replies, yes. Does that mean no medical cannabis regimen adjustment is needed? But if we ask the quantitative question, what number do you rate your insomnia with the medical cannabis regimen you're using now? Jennifer replies, okay, it was an 8, now it's a 4. So does that mean there's no need for adjustment, or is there? But the fact that it's not a 0 or a 1 kind of tells us, let's dive a little deeper. So we asked Jennifer, why are you rating it a 4? She says, well, I fall asleep fine, but I wake up at 2 a.m. So that prompts us to ask her, well, which medical cannabis products are you using? Well, she says, I'm inhaling an indica flower or vape pen at bedtime. So she remembered that from her education we gave her the first time. Indica inhalation will get you to sleep, but she forgot the rest of it. So obviously we know what's happening here. The inhalation's getting her to sleep, but it wears off. It's not keeping her to sleep. So we tell her, let's try adding an indica capsule or edible for longer duration of action, in addition to the inhalation to get to sleep. Now when we see her at her next follow-up visit, we ask her again, now what do you rate your insomnia with the medical cannabis regimen you're using? And she says, it's a 0. I said, I fall asleep just fine, but now I stay asleep, I wake up refreshed. So that tells us that no medical cannabis treatment regimen is needed at this point, and it's helped us help Jennifer get the best possible result from cannabis. One more patient, meet James. James has chronic pain following a motor vehicle crash a few years ago, which he rates as an 8 out of 10. He also has anxiety, which he rates as a 5 out of 10. At James' follow-up visit, after getting education, of course, the first time, we ask him, what numbers do you rate your pain and anxiety with a medical cannabis regimen you're using? And he says, well, my pain goes down from an 8 to a 5, but my anxiety actually goes up from a 5 to a 7. So again, obviously, this prompts us to ask James, well, what are you using? And again, despite the education we gave him at his first visit, he's listened to his buddies, and he says, oh man, I'm smoking a whole joint of the highest percentage THC flower I can find. None of us have heard that before, right? All right, so what do we recommend to James? Well, obviously, he's having paradoxical anxiety from too high a dose of THC, so we recommend lowering the THC percentage. We also recommend that he use a hybrid, since we know that some patients get more anxiety with a sativa, but better yet, we recommend he try a 1-to-1 ratio product, because we've read studies that show that CBD even alone helps anxiety. We've also read other studies that show that an equal amount of CBD with THC, patients report lower pain scores than they do with the same dose of THC alone. And we recommend that he not smoke a whole joint, but titrate the dose. Take a puff, wait a few minutes, take a puff, wait a few minutes, et cetera, until he gets adequate relief or until his relief plateaus and it's not getting any better. So when we see James the next time, we ask him what's he using now, and he says, oh, now I'm using 3 to 4 draws of a 1-to-1 vape pen and a 10 milligram 1-to-1 capsule, and with that, my pain, which had gone down from an 8 to a 5, is now down to a 2, and my anxiety, which had gone up from a 5 to a 7, is now down to a 1. So again, by tracking the actual severity of his symptoms, it helped us know when to drill down and to find out be sure we know what he's using and to make recommendations to help him get the best results. Another patient outcome we can track if we want is controlled medication use. For opioids, they can be tracked by measuring the daily morphine milligram equivalents, or MMEs. For benzodiazepines, they can be tracked by measuring the daily lorazepam milligram equivalents, or LMEs. I'm sure all of us see patients that come in and say, hey, I want to use medical cannabis because I want to come off my controlled meds. And that may or may not be a reasonable goal for them. And then on the other end of the spectrum, we see people who are deathly afraid of any reduction of their controlled medication dose. So it's important to reassure both groups that, hey, the goal isn't necessarily to get you off or reduce your controlled meds. The goal is to get you the best possible relief with the least side effects. And if that's medical cannabis and your current dose of controlled meds, fine. If it's medical cannabis and less controlled meds, hey, better yet. And if it's medical cannabis and no prescription medicines, obviously that's great. But again, the goal is the best relief with the least side effects. Now, it's easy to obtain the number of MMEs and LMEs that patients are taking. In eForce, in case you're not from Florida, that's Florida's Controlled Prescription Monitoring Program. It actually provides it to us. I don't know if you've ever noticed, but if you just follow the line across, you can see it provides daily MMEs and LMEs. If you're not from Florida and you don't have a prescription reporting system that provides the MMEs and LMEs, there are plenty of online calculators for converting to MMEs. You simply type in the total daily number of milligrams of the particular opioid, and then it'll convert it to MMEs. Likewise, for LMEs, there are benzodiazepine calculators. You just type in the total number of milligrams per day of the particular benzo the patient's taking, and then ask the calculator to convert it to lorazepam, which gives you lorazepam LMEs. We do document in our medical record the number of MMEs and LMEs a patient is taking, if they are taking controlled, and we document what amount they were taking when they began medical cannabis therapy, and then we update it to see how much they're taking, as therapy goes along. This is from an actual patient, and you can see that they had been on 8 MMEs of an opioid, of a benzo, and 4 MMEs, even my glasses, I can't see. 4 MMEs of alprazolam, and they were able to discontinue it. They were on 30 MMEs of hydrocodone and were able to discontinue it. So that's individual patient data. Now, in addition, we can look at cumulative data for all of our patients. We do this just using a simple homemade Excel spreadsheet. We list the patients on the left-hand column, individual patients, and then across the top we list the different outcomes that we're interested in following. You might notice that with the initials, we have 2 letters of the first name and last name. The reason we do that is because when we want to go back in and find the patient again at follow-up using the Excel find function, it's a lot easier to have more data for it to look at. There's a lot of people who be BH, but not that many BAHE. So for each outcome that we're looking at, in this example, pain, we have a column to enter the patient's pain score that they gave us without cannabis treatment. We put that in the pre-column, and then there's another column to enter the pain score that they give us while they're using cannabis. We put that in the post column, so we enter those numbers and then set up the spreadsheet calculation, so it calculates the reduction. So for example, here, the first patient listed, we entered a pain score of 4 without cannabis, a 1 with cannabis, and the spreadsheet tells us that's a 75% reduction. Likewise, the next patient, they said it was an 8 out of 10 without cannabis, a 4 with, 50% reduction, et cetera. But let the spreadsheet do the calculations. We just enter the data from the chart. The symptoms we track are pain, anxiety, and insomnia, because that's what we see the most in our practice. And then we have one other category we call other, which is all the other things that we might see, whether it's tremors, nausea, anorexia. Now again, in your practice, you might see other symptoms more commonly, but you can track whatever you want. We also do cumulative tracking of MMEs and LMEs. So just like with the symptom severity scores, we put the number of MMEs if a patient is taking opioids in the pre-column, the number of MMEs they're taking when we see them in follow-up at the post-column, and then let the spreadsheet calculate the percent reduction. So for each category, results are pooled to include all patients that have data in that category. If they're not being seen for pain, they're not counted in the pain calculations. If they're not on opioids, they're not counted in the MME calculation. So here's an example of the kind of information that you can get. For pain, patients reported an overall reduction in their pain score, pain scale scores of 77%. Of all patients seen for pain, patients reported that it was 77% reduction with medical cannabis compared to their pain score without using medical cannabis. And we looked at the range. It was a low of 13% reduction and a high of 100% reduction, as they're saying that, hey, pain's gone completely while I'm using medical cannabis till it wears off. Likewise, with anxiety, patients reported an 84% reduction overall in their anxiety severity score while using medical cannabis compared to when they're not. A range of just a 10% reduction to 100%. Anxiety's gone completely while using cannabis. For insomnia, 87% reduction overall in their insomnia severity score, with a range of a low of 13% improvement to 100% improvement, basically sleeping like a baby while using cannabis. And in our other category, it was 83% overall improvement, range 29%, 100%. Likewise, we can look at the cumulative results for the opioids and the benzo dose reduction. In our experience, 83% of patients who were using opioids were able to reduce their dose somewhat. 84% of patients taking benzos were able to reduce their dose to some extent. We're curious to see how many were able to discontinue them altogether. 31% of the patients were able to discontinue their opioids altogether. 34% were able to stop their benzos altogether. Pardon? We need more proof. All right. Now, the overall results, the average reduction in opioid dosage, the average reduction in daily MMEs was 53% for patients taking opioids, with a range of minus 140%, meaning that their opioid dose actually increased despite medical cannabis treatment. And this was a patient who had a severe, progressively painful condition, to a high of 100%. As we said, some people were able to discontinue their opioids altogether. With benzos, it was a 63% average reduction in their LMEs from the use of medical cannabis, with a range of 0, no change in their dose, to 100%, or stopping it altogether. In addition to clinical outcomes, we also like to look at demographics just to get a feel of who our patients are. So you can look to see male, female, in our case 56% and 44%. Curious about age distribution. In our particular practice, 38% of our patients, 38% are over age 60, and 56% are over age 50. It actually was not a surprise to us because we do try to focus on the two patient groups that have the most pathology that medical cannabis can help the most, and that's our seniors and our veterans, military veterans, which is 13% in our practice. We were curious about how many patients who were seeing for their initial certification into the program were already using cannabis in some form, from the legacy market or someone else's medical cannabis. For us, 57% were already using cannabis before they decided to apply for their card, and 43% were basically cannabis naive patients. We were curious of how many people were certified under one of the 10 named conditions in Florida versus the similar to option. In our case, 22% named 10, 78% similar to. But again, if you get a lot of referrals, say from an oncologist, those numbers are going to be very, very different. We just wanted to know how many patients we were seeing for their initial certification in the medical cannabis program versus how many were already certified but were transferring to us. It was about 70% initial, 30% transfers. And then we wanted to look at marketing to get an idea, hey, what's working and what isn't. So we asked patients, new patients, how did you find out about us? Well, the greatest way was online. In addition to a website, when we first started, we were paying for Google Ads, trying to get the people's attention and get the word out. Of course, initially, the percentage of people finding us online was much, much higher. That's gone down in time as we build a patient base. In fact, we're not using Google Ads anymore. Currently, 46% found us online. And the one that has increased is referrals from other patients, which is now 23%, and of course, hopefully will continue to grow. Also, referrals from other physicians. Currently, that's 12% for us. Again, for others of you, that may be much higher. We had a category called friends and family, people that we knew or friends of friends. And initially, that was a big one for us until we started to grow. But currently, it's 4%. 4% of people just find us from our sign. And 3% found us through dispensaries where we leave brochures or cards, or dispensary employee lists our name along with other physicians that the patient may consider trying. For a while, we were advertising in a local magazine that's full of advertisements that go to certain zip codes in our area. But we really weren't getting that many people from that, so we decided to discontinue that. But again, by tracking how many people we're getting, we knew whether to keep using it or not. So in summary, what are some of the benefits of outcome tracking? Well, it can certainly help with your marketing efforts to decide, what's paying off and what isn't, help you get your biggest bang for your buck. It can also help you attract patients. If you know your outcomes, how much relief people are getting from medical cannabis, if you can get to patients, speak in front of groups or even on your website, when patients see the kind of results other patients are getting, that might attract them. And likewise with referrals, if you can get the word out to referring physicians in your area, pain management physicians, oncologists, hey, these are the results my patients are getting. We'd love to help yours. When they see the kind of results you're getting, that could prompt them to give you more referrals. Outcome tracking can also help you know your patient demographics. And finally, and most importantly, if you do nothing else, by tracking patients' individual outcomes, it can help you help them get the maximum relief with the least side effects. All right, I know we're going to save questions and comments to the end, but thank you very much for your attention.
Thank you very much, Dr. Hershfield. I think not only was it a great presentation, but I appreciate your willingness to be so candid and open about your experiences in your practice. I think that's one of the nice things about this conference. Everybody's willing to share and help, and that really helps all of us. Moving right along, who's next? Stu Baskin.
Hey, good morning, everybody. I'm Stu Baskin from CannaPlan. Thanks for having me out, and thanks to Gene and the steering committee for giving me the opportunity to talk about how cannabis can help employees and their companies. So I'll talk about the actual prescription costs for companies, how cannabis is benefiting employee wellness, and then corporate growth and attraction and retention of employees. But first, I'll jump into an extensive history of cannabis as a medicine. Just kidding. I know you guys are well informed on that, but I will give you a brief history of CannaPlan. So we're a startup based here in Orlando. We offer the premier medical cannabis employee benefit. The reason I say that is because no other company offers this, as far as I understand. We're the first and only. So we offer opportunity for employers to contribute to their employees' physician visits and then dispensary visits. So they basically can put money into an account for their employees to use, kind of like a cannabis HSA. And once we're rescheduled to 3, that can be a pre-tax employee benefit, which will be even better. The other side, we offer our educational workshops, which there has been a lot of discussion over here. We try to teach our members about the endocannabinoid system, what specific cannabinoids can treat specific conditions, what drugs can be replaced with cannabis, and then kind of employee health and wellness, about diet and exercise, and how to be your most productive and well self. The benefits for our member companies, we try to reduce prescription expenses and do that by lowering prescription use and healthcare expenses. We want to give a natural alternative to those chemical prescriptions, and by doing that, we can decrease workman comp claims, time off, injuries. We can increase employee retention, maximize productivity, and boost company valuations, and also attract new employees. So I'll talk real quickly about prescription costs to companies. I'm sure a lot of you are familiar about this. But employers that pay for premiums for their employees, either in full or part, are contributing part of that towards their prescriptions. So the healthcare providers have an allocated pool of funds that they pull out every year, and they say this is what will allow the company employees to spend on prescriptions. If the company goes over that, they raise the rates. The providers don't tell us how much they're putting into that or how much they're charging for drugs from that. So I'm sure you can see a pretty big issue already developing with that. I assume that they charge retail. There's no information otherwise. Maybe they put fees on, maybe not. Hard to say. But ultimately, employers are contributing to their employees' prescriptions directly through this means or indirectly. So prescription usage in the U.S., we see 70% of adults taking 1 prescription and 24% are taking 4 or more. That is a staggering number of people on medications. And somebody actually commented to me on this, wow, there's 30% of people that aren't taking anything. And I said, well, people medicate naturally, and those aren't included in these prescription numbers. So I wonder how many of that 30% do medicate with cannabis and other natural means. How much do you think we spend on drugs each year in America? There's the 2022 number, $633 billion. Yeah, national debt. So yeah, this is coming from employers and employees, and the contributions to this system where it's perpetually increasing prices because they can is driving this every year to go up. So the biggest health challenges, Dr. Tamar yesterday talked about the 4 horsemen. I switched out the neurodegenerative diseases for opiate addiction, but this is from the National Institutes of Health, our 4 biggest challenges. And we know that cannabinoids can help the body overcome these naturally by helping to slough off cancers and break them up, reduce the inflammation that drives heart disease, CBD to directly help people overcome opiate addiction, and then diabetes. Dr. Berger actually talked about THCV yesterday for appetite suppression, and that's something that's becoming more mainstream. And so these are the things we like to talk to our members about. You know, there are a lot of non-psychoactive cannabinoids that can be incorporated into a regimen so that people can comply with drug-free workplace policies during the day while still being able to medicate and not taking drugs that will alter their mind. And then in the evening, to help their sleep, they can use the more psychoactive or THC-based cannabinoids. All right, so let's talk about employee wellness with cannabis. So we're in a pharmaceutical marketplace. Employees have conditions like pain, sleep problems, depression, anxiety, and a whole list of others that they go to the doctor for, and the doctor says, take this pill and you'll feel better. And they might feel better, but it's not necessarily treating the underlying cause. It's just masking the symptoms, the pain or depression. But we know with cannabis that employees can find a more natural means to get their body moving and actually find wellness that overcomes these issues naturally. I call the employee's problem the trifecta of unwellness. So this impacts over 50% of employees in the US every year. And I feel that these conditions all work together. So be it working inside in the heat or outside in the heat or inside at the computer or standing at a register, the stress builds up, starts causing pain in the shoulders, back, neck, and that can lead to anxiety, depression, sleep problems. And so all these just go hand in hand. And employees are given essentially a prescription for each of these. Here, take this pill for this, take this pill for this. But these prescriptions cause a variety of side effects, which I'm sure you're also aware of. So these non-opiate medications, the common side effects aren't going to impact a worker that much, but once you get into the severe side effects, this is definitely going to start impacting workers' productivity. And then when we start looking at the opiates, there's the even more severe side effects. And then we start getting into the addiction and what kind of choices that can lead to and worker loss from overdose, coma, death, things like that we definitely don't want to see anymore. Some of the side effects of anxiety medications. You'll notice anxiety is one of them. So that was interesting to me. And then depression medicines also, you guys understand that all of these cause side effects. Some of them can be severe, and with the depression medicines, you have that black label side effect of suicidal thoughts or depression. Definitely not the same case with cannabis. So if we can start transitioning employees off of these chemical pharmaceuticals and more to cannabis as a treatment, they can benefit naturally and reduce all these side effects that hurt their productivity. So what are some of the actual benefits of employee wellness? I brought my cheat sheet for the exam. So this is a report from the National Bureau of Economic Commerce from 2020. And so they saw that with recreational marijuana legal states, there was a decrease in workplace injuries. So the injuries for severe injuries only went down by 4.5%, but the minor injuries went down by almost 25%. So that was a pretty major reduction. And that leads to the workman's comp income reduction. So with that, there was a 6.2% reduction in claims of work loss due to injury, but there was a 20% reduction in overall workman's comp income. So that's a pretty solid number on that side. The lowered opiate morbidity, 20 to 35%. That's major. If we can push that more and get people moved away from opiates and onto cannabis as an alternative, we can solve that huge problem, the opiate epidemic. And then less prescription usage overall. Bart was mentioning that's great research that's coming out from multiple angles of people that want to give up chemical prescriptions in place of cannabis, and we're seeing that be effective. And so that previous study looked at 40 to 62-year-olds. This study looked at 51 plus workers. They saw lower pain across the board, better self-assessed health, increased labor supply, so older workers were more able to go back into the workforce once they got off of those pain prescriptions. And then the reduced workplace injury that I just was discussing. These factors, hand in hand, really they're towards employee wellness, but they can really boost a company's growth by reducing those expenses and keeping their employees on hand. So we can look at some of the actual corporate growth numbers. So this was in states with the recreational marijuana laws. Actually, this one's for medical marijuana laws only, I believe. But so this report came out of the University of Iowa's College of Business. So I didn't find it in any publications, but I contacted the author after finding an abstract and looked at kind of their statistical analysis. I'll give a couple points on that at the end, but overall, market-to-book valuations for publicly traded companies in medical marijuana legal states go up by 9.5% compared to non-legal states. So that's a pretty big corporate boost right there. Patent production and citations went up, so the production went up by 14% for companies in those states, and the citations went up by 19%. So it seems like there's more innovation getting driven to those states. They also saw the revenue per employee increase. This report was kind of limited because it only looked at the publicly traded companies, and the laws kind of vary in every state, so those have an impact. But overall, this is something that we as a company definitely want to look into, and so we're going to be doing surveys with our member companies to try to gather some of these metrics going forward, especially in the private sector. So we have employee surveys and company surveys that we can gather this data from. And just to kind of bring it all together, so the benefit to employee wellness that also benefits corporations is the lower prescription expenses and healthcare costs, decreased workplace accidents, and of course the increased productivity, corporate growth, and value in the competition in the workforce, which drives salaries down. It's not that great for employees, but good for companies. And we'll talk about attraction and retention. So once you find your top talent, you want to keep them. And who are companies trying to attract? So all of these classes of people are definitely cannabis users, because I think every class of people has cannabis users in it. But recent grads in particular, the study cited here shows that they're using a lot less alcohol and a lot more cannabis. So if companies have a drinking workplace culture, that's not going to be very attractive to people that don't drink. So by having things in place like a medical cannabis employee benefit, you show your potential employees that you're an inclusive workplace. Young professionals are finding out more and more that they can treat their anxiety, pain, and depression like I talked about with cannabis, so they're moving away from prescription drugs. Those reports citing older workers that have the benefits from switching from cannabis or switching to cannabis from the chemicals. And yeah, I don't think there's any age group that doesn't like cannabis. And then employee retention. So in high turnover industries, there's a lot of job hopping. So restaurants, retail, dispensaries, any hourly wage where they can move to a competing company that's going to be able to increase their pay by $1 or $2 per hour, they're probably going to make that jump. It's a pretty easy decision. And especially in mid-September when the non-compete laws are banned, I suppose, then we're going to see a lot more of this turnover happening as the competing companies start to poach employees from where they work. Reducing training costs, so every time an employee leaves, it's about a 3-month cost of salary to train the new employee, the replacement. And when an employee leaves, you might not be able to gain all that knowledge or retain all of that knowledge that they're leaving with. And this is particularly important if there's a sudden death or departure, like from an opiate overdose, where that employee's knowledge and job is just immediately lost. And so there's not really much way to come back from that. And yeah, the opiates are kind of the main problem we're looking at. That's, you know, the other drugs, they have their side effects and they're a problem, but opiate overdose is just such an issue in this country right now that anyone that we can get to move away from that onto cannabis is going to just benefit them, the company, and society as a whole. So that's kind of our primary goal as a company in that sector. And I think that's about it. I ran right through it.
Thank you, Stu. What you may or may not know is that there's a timer here to let the speaker know how long they have to go. And Stu started, and for some reason, the timer didn't start. And so, like the novice moderator that I am, I panicked. I didn't quite know what to do. But of course, Stu handled it like the pro that he is. So thank you for doing that. All right, who's next? Brad Hunt with Pro Mountain Shirts. Then Brad walks out, which I have no idea what to do about that, but fortunately he's back.
Hello, everybody. And first off, I'd like to start by, before we all go back to our work Monday, let's thank the sponsors, all the presenters, and in particular, Gene. thank you, Gene and the team, for, I think we all learned a lot, and my expectations were exceeded because it was such a great format and it was organized well. So let's bring it home here and then go do our good works for the week, right? So like a few of you, I'd like to start with my passion and my purpose, your story, how you get into it. So I played football at high levels, Division I athlete, and I used cannabis to get through that experience. It's traumatic. I was a poor kid. I had a scholarship, which I was told to be grateful for, while I maimed my body, and I got about a concussion every 2 weeks, literally. So it helped me through that. Now I use it for, I'll say it, performance enhancement in business and in my life, being a better dad, being a better husband, right? So that's kind of my passion, I'd say. My purpose is I've spent the last 25 years, now get to work at the highest levels of healthcare, with healthcare systems, state-level associations, physicians' practices, nursing home chains to protect the patient, number one. If they get hurt, I'm an insurance person and I'm a risk manager. The worker, and in my world right now, worker safety equals patient safety, and vice versa, right? It's my mantra for the next few years, right? So, I get to work in this realm, and I get to see the mayhem of that, right? And 6 years ago, Peter, Barton, and I was working on several things: infant mortality, the opioid crisis. I saw a lot of people through the pandemic, handling the worker deaths. It was exhausting, right? And Peter and I, in 2018, and a bunch of other professionals, there's a group of us, CPAs, MBAs, professionals, attorneys, and we've been working on this since 2018, right? And this is part of the purpose. I saw a risk in healthcare. I saw an uneducated physician group, a too eager patient population, and an experience where your doctor says go get medicine, and the quasi-pharmacist says, here's what's on sale. So we don't so we want to close that chasm, number one. Okay, so we came up with ProMal Insurance. So what I'm going to do is I'm going to move to an explainer video, which I really think kind of gives us what ProMal is and what it does. But before I play that, I want to give you some information, because usually, we've been down here at several conferences, but today we're, thank God, speaking to the choir. Usually we're trying to convince physicians that are in other specialties that cannabis is something you do need to learn about. It is part of the care plan. You do have a burden to understand a system in the body, at least, if nothing else, right? So there's a little bit of I'd say a tint of get excited sensationalism, so that's not for you, number one. Number two, what you're going to see here, and the significance of the work we've done, is that it's malpractice insurance. It's going to cover you for cannabis from a high level if we're in a balloon looking down on this, right? But it's more than that. We went to the Florida Office of Insurance Regulation. We went and got it legit. We didn't run to the Cayman Islands. We didn't go to Bermuda or, Lloyd's of London and say, hey, we're going to do this offshore. We went and said the same state that calls you a doctor through a different agency, has deemed this through extensive review. Believe me. They know the questions we're going to ask you, they know the price we're going to charge you, and they know the coverage we're going to give you, and they are perfectly encouraging us to do this because it does give the patient the right, if they are unfortunately harmed, they can be made whole, and that's important, right? And your career and all the work you've done is not put in jeopardy because now you're demonized for that. So I think we can sympathize. Peter's back there. Put your hand up, Peter. Jesse Walls is with us today, too, and we have been in the public square, and we have been stoned almost to death. Right? It's got a couple layers to it. I like that one. Right. So with that, we'll get you excited with ProMal, and I want you to all think about, what we've learned here. I've learned some things from chemistry to culture to why goats eat weed. So take that work home and do your good works. We'll get you excited about this, and we want to help you run a better business in general. So here's how we're going to do that. Oh, my IT guys don't let me down. Do I got to hit something? Oh, now I just messed it up. Look at me. All right, back.
Here at the Boys and Girls
on. So if this doesn't play, we're going to my booth, you're standing around and we're watching it. What do you think, guys? Should I run through it? All right. All right. Maybe at the end I'll give you the commercial then. We'll give you the timeshare version of this. You're going to, if not, but let me get into it because it is a life's work for us and our team and it's important. So we are protecting you from what we've coined as the cannabis malpractice gap, all right? We provide insurance. We want you to do your good work. So we don't care how many patients by percentage use cannabis in your practice. We hope it's every one of them, right? Because you're less risk to me as a healthcare risk manager. All right, I deal with the mayhem of healthcare, the nurses being beat, the people taking the wrong medication, patients breaking their hip because their care is not appropriate. We want you to go do your work with cannabis, make people well, run your business. We're here, we empower people to run better healthcare businesses so you can spend your time on what you do. All right, we are affirmative. You have a cannabis claim, we're not going to say, well, let's talk to our lawyers. No, we're going to come like the cavalry. If you made a mistake, let's clean it up. If you didn't make a mistake, let's have the peers in the room defend you and say you did nothing wrong and that we had, done the right thing. Because we have witnessed, I told Peter the other day, I said, this is amazing. I'm sitting over here watching the standard of care develop before my eyes. It needs to, it's not there yet. Some people have done more work than you think. I'm going to show you something on that now, all right? So that's what we do. We empower you to run your practice. I want to see you guys be a specialty. I want the state to say, we've done that at the Department of Insurance, by the way. We went to the Department of Insurance and said, okay, they used to be an anesthesiologist. They used to be a spine surgeon. They used to be ER. But what do they do now? They do holistic medicine. So if you have a policy for, what you used to do, let's take a look at you. Let's make you a cannabinologist. Because the Florida Office of Insurance Regulation recognizes that as a medical specialty. But there's a department in the state that doesn't yet, right? Anyone know who that is, right? State Medical Board. So, right, we have to go to them and say, hey, another state agency recognized it. Thanks to the team, pro-mal fighting for that, all right? Let's go through it. All right, so back in 2018, we were figuring out, do we have something here? Is there a problem for us to solve? And we did work with Dr. Out of East Carolina University, all right, Dr. Brenda Wells, and she is a PhD in insurance. So she had her students contact 15,000 doctors in 7 states in a research study and ask them a few questions. And we did it regardless of specialty and regardless of their stance on cannabis. Pretty random. Thompson data, are they a doctor? Send them a survey. And the results we got back are as following. And I want to see, some of this is non-cannabinologists, so take it with that, but follow along. And maybe we'll do some confirmation of the data here while we have a test population, right? So physicians across specialties are reporting patients asking about cannabis several times a week. That's 100% for you, but we're seeing it in the specialties, right? Oncology, psychiatry, OB. We're seeing it across the spectrum of care. Because when you work with a patient, they don't just see you, right? They might see several other doctors. And that doctor has to be knowledgeable. And I can tell you for a fact, I know you're burdened here, that doctor's not talking to you about the wellness of that person. Often you facilitate the care, but you're not incorporated in the care. And that's something you can change. 62% of physicians have no confidence they have coverage for what will now be known as cannabis wrongful acts. We just sat and met some folks that have attended the conference, and we kind of did some side huddle work with them because they were just testifying in a malpractice case, defending a doctor against a patient who was unhappy with their cannabis use outcome. So we all know it's safer than the alternative. I've been in the trenches. I worked the pandemic. I worked the opioid crisis. I worked infant mortality. I know we have a safer option here. I know we'll get better outcomes. But in the meantime, you have an uneducated physician group that is the primary care physician, an eager population of users, as I said, and we're going to have some unfortunate outcomes, right? Next, 87% physicians who are calling for more cannabis education. I think we're all in that wagon together. 95% regularly ask their patients about cannabis, but how? All right, due to my trauma on my rib about 2 months ago, I had my rib extracted, my 11th rib, and I told the anesthesiologist, you're not going to touch me until you take my CME on. I might wake up on this darn table. And she told me nothing to see here. And I said, again, I'm going to the surgeon and saying, get a new one if she won't listen, because it's my body, right? And she fortunately eventually incorporated it into my care, but then they filled me with fentanyl while I was out. Unfortunate. All right. 96% physicians who believe cannabis-related malpractice claims are possible. And me and Peter said, we got to go raise some money and get this done. And this is the look we typically see. What? Cannabis? Right? You know, I want to talk to you about a thing called risk transfer. You know, if a physician sends them to you and says, hey, you deal with the cannabis, you send them back to them. If they get blamed for the cannabis, who are they blaming? I sent them to another professional who gave their opinion. Go talk to them, sue them, right? Don't be that deferral, right? We can give care, we can make people well, but we have to have integrated medicine, and we have to challenge some things here as far as stigma. So when we do talk to these physicians and these other specialties, what we're seeing is they're saying, you know, what do you ask every day? You guys facilitate these discussions, but this is what the patient's bringing up. Right? I can see it right now, the weed commercial that replaces the pharmaceuticals is like a joke. Ask your doctor about, right? Side effects include happiness, better marriage. But this is what you can see the questions up there they're getting and they're unable to answer, right? They are unable to answer. And that causes risk, that causes malpractice, potential liability. We need to protect ourselves, our life's work, and you know what we're leaving to our families, right? Education, we're going to continue to partner with Gene and his team. We're giving away, I hope you did stop by our booth. Before you hit the plane, we have a free CME on the endocannabinoid system. If you don't take it, hand it to a friend who you're still trying to bring along. All right, we have Cannabis Grand Rounds. It's a monthly event hosted by the Doctors Knox, who, Janice, Jessica, and Rachel. I know some of you do know. They're partners with us on this as far as education. I got 5 CMEs right now. Worth it on our website, because again, I'm education first. I like to ensure things that I know aren't going to have claims, because I've educated the healthcare system and the professionals on how to avoid them, right? How to do things like waivers. They are important. Even if you are an advocate of cannabis, you need to have a waiver so that you have informed consent. That's a way to document it, right? So education's key. We're going to be here to keep providing it, and there's some free ones on our website now. Please use it. Give it to a friend. We've talked about this a great deal throughout. How do we convey what the medicine does to the end user? So we're out there training doctors on how to read what's there. We're looking for you, the industry. I love that we have industry here and healthcare. That is so important, and we need to continue this. All right, the people who make it, the people who prescribe it, and we need to have a connection with the patient in the middle of that. But they need to know how to read the labels. We travel, Peter and I travel, we've gone to dispensaries on Indian reservations, every state you can imagine. We get to fortunately go around the country, and it's confusing as can be. We know what we're looking for, and I got, a bunch of I call aunts and uncles on our medical board, and people we insure who, concerned about my wellness, and I got a call. So what's the average person's experience? I often ask that when I'm out about. What is the patient experience? Learn it, think about it, live it, so that you can drive it, right? Go in their shoes. You guys know the stuff on the left. We're usually trying to convince people it exists that are physicians. But on the right is our world. So I'll tell you this. We have in our country what's known as the National Practitioners Data Bank. You guys know what it is? When an insurance carrier has a malpractice claim, they have to report it. It's categorized, and we use it for research and so on. So there is no drop-down box for cannabis. It will be soon. Not anytime soon, but soon as far as like later. And on the right-hand side are what we work on every day now. So when the actual claim comes in and there's cannabis tied to it, right? There's a guy in New Jersey who's built his entire practice, legal practice around, were you harmed by cannabis? Call me. It's time to get what you're due, right? He has a website. We show it to you. So on, the claims that you see there are failure to assess drug interaction. You look at those top. I'm not going to read them because you guys are practitioners. So improper intake. When you go into healthcare systems now, they still ask about cannabis as a drug of abuse on the intake right after, is your wife going to beat you? You guys know what I'm talking about on the intake, right? So I answered that question in my several interactions as I am a legal, card-holding, legal, every other word user of the legal system that my medicine I'm taking should be put in the other column, please. I abuse nothing. I'm under the care of 36 doctors. So it's how you ask it as we tell our friends, that makes the patient feel comfortable that I can talk to you about my personal issues, because healthcare is insanely personal, right? And if I don't feel like I can trust you, I'm not going to tell you a key bit of information you need to make me well, right? So it's all about how you're perceived. So these claims over here are real, lack of informed consent, right? I wasn't walked through what I'm talking about here, all right? Improper patient management. I didn't have follow-up. Well, I saw you and then I see you every 8 to 12 months. Well, are you a doctor involved in my care, or what is this side hustle thing where, we're not having the patient in the middle? Improper treatment, improper documentation. I'll give you a story on improper documentation. Had a physician with an infant, got the second physician on board. It was Oregon. A couple gentlemen that are in their age, they lost a paper, right? Parents were buying tincture that was heavy CBD, very light THC. It's an infant, appropriate, right? Dispensary runs out. Dad goes to buy the bottle. Hey, where's the new brand? It was flipped. He bought the THC heavy, and they were using it into the infant. The infant got life flighted. Activist physician in Oregon said, I'm going to bring an action on the state medical board. And that's usually what will happen, and then the attorneys will start saying, okay, once I got that win, I got you as negligent, I'm going to find the people I can convince were harmed, and now we got the suits, right? So that's how they do it. So there's also options to defend on that level as far as keeping your license, different thing than prom out here. So we also see what's called the sin of omission. We use this in our other speeches when we say, my father, 30-year prison guard on Xanax withdrawal. It's been hell getting him well. It's been a 3-year journey. The entire time the physician said, if you put him on cannabis, University of Pittsburgh Medical, I'm going to drop you. I'm going to drop you. My father, who went and, handled murderers and rapists for our society for years, can't use cannabis still to this day. So there's the sin of omission in cannabis. You didn't give it to me as a viable treatment option. You're going to see this in the PTSD claims and in certain claims where, you left it off the table when it's a viable option. Everyone on my platoon is using it. Everyone who didn't use it is almost dead or dead. So I think the people surviving me have a case maybe, and that's where malpractice can come into play. All right, these are the allegations. So there will eventually be one for cannabis-related wrongful act. We are the only company going to track them. We're going to help set how much do they cost, what should they cost, and we're ready to defend them. We know what they're going to look like. We are handling them, and again, it's like a lot of malpractice. You're really not buying it for when you get up every day and try to make people well. You're a risk manager by the minute, right? You're a healthcare provider. You're not looking to make a mistake. So usually these allegations are somebody that's unhappy. I don't like the outcome. Who can I blame? Well, there's no Purdue to sue here as opioids go, right? So who are they going to go after, right? You don't work for a healthcare system, so there's some risk there. So we can mitigate that. Most of these lawsuits are just protecting your good name and works, and we say goodbye, but that does cost some money to bring an attorney in and make your case for you. And that's what malpractice does, all right? And that's how we've kind of structured this. All right, so they can happen. So, when we go out and about and we talk to physicians, they say, well, I'm fine. Number one, my healthcare system said don't talk about it, so they'll back me up. Right? And then there is no standard of care, so how can someone get on the stand and say, I made a mistake? Okay, let me ask you something. You're a physician. Do you know that there's a system in the body with receptors that regulates the other systems? That's horse pucky. It's not about the flower. It's about a system in your body, and you're a physician. We still get this level of pushback that, well, that's not evolved enough to where I'm going to be held to it. But look at that list underneath there. I made a living working with healthcare associations. That's how I work at the association level. You said it earlier that, healthcare is one of the only industries that when we find a good idea, we Paul Revere it and everyone gets it quick because it's about the people. You figure out how to do something in another industry, it's a competitive advantage and they'll share it. But in healthcare, that's why I love working in it. Right? So in these organizations, they've at least written what I'll call an embryonic standard of care, which is going to go to kind of basic stuff like make sure they're informed, make sure your intake's proper, make sure you listen to them as a human being, fill out some good forms, tell them about the risk. And now they're starting to form working groups, and some I'd love to do down here. We tried to do it with the anesthesiology group. They're doing some work. but they have some other priorities. And, we're looking for, the physicians to tell us. We're not clinicians. We are the defendants. We defend you, right? We defend your business. So we need that standard of care to evolve so we know that if someone has, followed what we're all saying is a way to do it, or they're a little off the rails, right? Either way, we're going to help them. We can't have people not being successful in this, right? So there's another myth. I'm not liable because I did not prescribe. Now, the Schedule III kind of melts that. But also, are you physician of record? I'm not physician of record. It's like, again, there's no Purdue. There's 2 doctors. They're richer than me. The broke person hurts. So who am I going for? Right? That's how it is playing out currently, right? So we had some folks talk about their testimony. And Peter, what did it come down to? Just patient unhappiness, right? It was the basis of the suits right now. Patient unhappiness, not you got the science wrong, you got the dose wrong, I thought this was the cure-all, it's safer than aspirin, and everyone else says it's the most amazing thing on earth, and it's not working for me, and I'm blaming you, right? So we know how to handle that from a bedside manner, we know how to handle that, that we are science, we do follow science, we are spiritual, we try to heal people, but, people have their own reality sometimes, and they need someone to throw a rock at, right? So the national associations are alerting physicians that, there's more here to see than your high school dime bag, right? So it's starting to get out there. Here's some of the prominent names. You can read them, right? You can see them. American Academy of Neurology. What's that? We always quote this one study of the oncologist. 70% know their patients are on it. They don't know how it works, but they're cool with it. That's a terrible study result, right? And that's the kind of stuff we're seeing now. Maybe there's something here. We're still seeing FDA talk about hemp stuff, and there's, even consumer concerns going out on that. So what's the real stuff should we be concerned about? Then there's the sensationalism. There's also just more findings and studies. And, as these ability to do clinical trials and things increase, we're going to see more of the harm-related research too, right? It's not going to be all panacea. It's going to be all Department of Health and Human Services. It'll kill you, right? So, we have to understand when the patient walks in the room, they're going to be reading this stuff, right? The old WebMD scenario. But now it's not just WebMD. It's ARP, it's The Economist, it's CNN, it's Wall Street Journal, right? Informing them, go in and ask your doctor about this, right? So again, you have to be more informed, you have to be confident, you have to manage expectations, I'd say. All right, that's usually your job as a leader in general. So consider that. So back to how we protect you. What is this? How does it work? So we are affirmative again on medical malpractice cannabis gaps. So let's talk about how the gap's created. How many of you in here have and continue to maintain primary malpractice insurance? I'm not saying you have you click the box for financial responsibility. You have a policy with a declarations page from a carrier. Okay, that is very encouraging. Thank you. Yeah, a lot of times we hear, I got $250 in a mason jar, let's have at it. No, that's not appropriate, right? The gentleman that's being in court right now, being defended by one of our peers, has no primary coverage. So they're paying for lawyer out of pocket to protect their license at this point, right? So what happens is you have that primary malpractice policy. I'll use some names because we have them and we read them, the doctor's company and so on, right? They have a section in there, it's section 5.2 if you want to look at it, and it says, if this claim involves a non-FDA approved treatment or drug, good luck, we're out. So descheduling has zero to do with this. Right, that just says due to research. Until the FDA said that cannabinoid, that modality, these comorbidities, study approved, you can claim it, that malpractice policy will continue to have that exclusion in it, and they can continue to say, I am not going to defend you, it's not FDA approved. All right, so we step in when that happens, when that trigger occurs, we step in and say, okay, we got you for $1 million on the claim, and we'll get to the kind of program components here in a minute. All right, but before that, let's go back to your primary policy that you pay. Number one, I said earlier, you might be paying on that as an anesthesiologist, an ER doc, a spine surgeon, right? Well, you don't do that anymore, so we can get that down. And I think we can maybe be able to get it down enough where you can afford to then add this and have a full ability to talk confidently about cannabis all day long in the sunshine, right? So why can't your primary do it? Well, number one, there was this, if you handle cannabis money, banks hate that, right? We had our education site shut down by PayPal because we were trying to sell doctors cannabis education. I know some of you have been there. I've heard the stories on the breaks, right? So people the big insurance companies have a very, very big, they don't like it at all, right? So they have, they're silent, they're ambiguous. You'll call your insurance agent and he'll say, oh yeah, thanks for telling me. No, black and white, this is a contract in writing. Tell me you're cool with it in writing or it's an opinion, right? And if you can't get it in writing, then we can add ProMal on top of it. That's how this works, right? You add it on top, and traditional insurers, they got conflicts of interest, federal and state laws, regulatory compliance, their board won't let them do it, their bank won't let them do it, so it took someone nimble like us to do it and get in there with the Florida Office of Insurance and get it rated, all right? So here's what we do, protect against the wrongful acts. There's no restriction the way we have structured it and the way you would join it that the federal government can come and shut it down in any way because insurance is regulated at a state level. But we did use kind of some federal stuff to get this going initially. It was insurance that you sell to skydivers. So you guys are like as risky as skydivers. So, but we changed it so it's more appropriate where you're joining what's called a risk purchasing group for a very small fee. The risk purchasing group gives you education. I'm a best practice nut in healthcare in my day job and on this, and you're gonna get that from me as well, ongoing, right? And the ability to purchase the insurance through a risk purchasing group that you're a member of, but tax liabilities are no concern and you don't have any votes or meetings to attend. It's a pretty good group to join to get access to this insurance. All right, we have $1 million per occurrence, $2 million aggregate. That is great coverage and it's affordable. We're quoting out here at the show at $1,500 a year, $1,500 for 12 months of $1 million in cannabis claim coverage, right? It's going up to maybe about $3,000 in some cases. It depends on your prior specialty. But again, talk to us about what to pick on the drop-down box, okay? And I am 43 seconds left, so I hope I gave you a good education on malpractice as well as our solution. Yes, Q&A? We want to move to Q&A? I'll defer to Q&A now. Yeah, oh, you got the video? Oh, perfect. I really hoped we would get there. So I should go back and click it?
Your patient's cannabis use puts you at risk because your malpractice policy excludes cannabis. ProMal Insurance protects you with affirmative cannabis coverage. Cannabis use is increasing rapidly, along with THC potency. Your patients ask about cannabis, and many use it. Your standard of care must now include cannabis, a complex drug of over 100 cannabinoid compounds that acts on the endocannabinoid system. THC and CBD can be harmful singly or have dangerous interactions with other drugs. You are personally exposed to cannabis lawsuits because your malpractice insurance excludes federally illegal drugs or those not approved by the FDA. ProMal provides CME education on cannabinoids and the endocannabinoid system to better equip you for patient care. Our supplemental coverage for cannabis enhances your malpractice protection for as low as $1,500 annually. Get a quick estimate of your premium at www.promalinsurance.com.
Thank you, IT guys.
Thank you very much. Thank you very much, Brad. We will hold questions till the end, but I will answer a question that many of you have because I can read minds. If you have a question in your mind that begins like this, can I get sued if? The rest of the question is irrelevant. The answer is yes. So you can. All right, Peggy, we're going to get Peggy up here. I think we call it the cleanup. Come on up.
All right, everybody's ready to go home, I know. Thank you for staying. Thank you, Gene and CanEd, for having me again this year. Like everybody up here, I'm all about the education, and I just wanted to give you guys some information on accounting, how to stay out of some trouble. This is me. I'm an accountant, and like all other accountants, I'm a member of the American Institute for Certified Public Accountants, and also the Florida chapter. Like some of my colleagues my age, I own my own accounting firm where we do bookkeeping, accounting, and tax preparation. But where I start to differ a little bit is I've been working in cannabis for 5 years. I've been working with physicians for over 15 years. Where I'm even radically different is I'm also a forensic accountant and a fraud examiner. I look at things through a little bit of a different lens than maybe other general practitioners in my field. I've written a book. Hold on a minute. I'm writing a book. I'm writing another book. As always, my materials are always free. This is just information that I have found that people ask me, and I wanted to put it all together so that there's a reference for everyone. That's going to be out in October. This is the preliminary table of contents, but we're going to look today at internal controls in a cash-intensive business because, like we know, we don't have access to the same banking as everyone else because we're all money launderers. So we have to deal a lot in cash. And so what I want to talk to you is about managing a cash-intensive operation. So a cash-intensive situation stems from current restrictions on banking and payment processing access for businesses in the cannabis space. Again, businesses that take in larger amounts of cash require specialized strategies for managing day-to-day operations. They're a little bit different from a traditional physician's office that doesn't handle a lot of cash. This creates challenges: secure cash handling, effective financial reporting, transparency in cash transactions. It also creates an elevated risk of financial irregularities in your financial statements, fraud, and internal control failures. There's also an increased risk of audit. The IRS considers you a cash-intensive business if you have a lot of cash going in and out. Even if you don't, the IRS looks at the entire cannabis space as cash-intensive. They have their eyes on you. The cash-intensive, the IRS is aware that it's easy for cash-intensive businesses to underreport their income, and they look for it. Cash transactions can be anonymous. There's no trail to connect the payor to the payee. And if there's no record of the transaction, it never occurred, right? Wrong. IRS examiners perform direct and indirect analyses on your tax returns, stuff they already have. And then when they come out to see you, they will look at your books and records, and that will reveal other underreported income. The IRS isn't going to send an asset out like an investigator unless they know that there is there. So the best way to look at this is we're going to look at a case study, which I call Dr. Mike's Bad Day. Dr. Mike owns a small medical cannabis practice. He has a state-of-the-art, read expensive, patient management system. It collects patient tracking data and point-of-sale data. This is completely made up for ease of calculation, but his appointment pricing structure is his initial certification visits are $250. Anybody that comes in for a recert, it's $200. So let's meet his staff. He has a receptionist named Annie. She works 8 to 5, Monday through Friday. She answers the phone. She maintains the patient schedule and waiting area. Here's his office manager, Daniel. He does whatever office managers do. He works from 8 a.m. to 5:30 p.m., runs the office, makes daily bank deposit, pays the bills, does the bookkeeping. He has 2 part-time office assistants. They maintain the patient files and they collect patient payments at checkout. We have Lauren that works in the morning from 8 a.m. to noon, and he has Emma that works from noon till 5:15 p.m. He has a medical assistant, Madison. She helps the physicians. She works from 9 to 5. There's 2 cannabis physicians in the practice. Dr. Mike, he owns the practice. He works from 10 a.m. to 4 p.m., and he goes fishing before and after work. Then there's Dr. Bob. He takes up all the rest of the slack. So yesterday, Monday, April 1st, like every other day after the very last patient left, Emma prepared the daily receipts report. She gave it to Daniel with all the cash and checks collected throughout the day, and then she left for the day. This report splits out how many initial appointments there were and how many renewal appointments they were. At the dollar amount, calculates out what the total receipts were, and that's how much cash and checks she handed over to Daniel. Daniel uses this report to enter the revenue into the accounting system, and he also prepares the deposit ticket. As usual, after completing the deposit ticket, Daniel then places both of those on Dr. Mike's desk and takes the receipt or the deposit to the bank, and he drops it in the overnight repository. Because the bank's closed, it's late in the afternoon. When Dr. Mike came in on Tuesday morning, he reviewed the two documents, the daily receipts report and the deposit ticket. The balances matched, total receipts, total taken to the bank, everything looks good. Dr. Mike then went into the system to enter additional appointment notes for a very familiar and longtime patient that he saw yesterday, but he couldn't find the appointment in the system. He asked Madison to help him, and she said that the appointment was showing as canceled. Dr. Mike knows for sure that he saw the patient yesterday and remembers having a lengthy conversation about fishing gear. Madison then pulled up the patient's record in the system. She saw that the appointment was initially scheduled back on March 5th by Annie. Sounds right. The appointment was scheduled for yesterday at 1:30 p.m. with Dr. Mike. The appointment was then canceled yesterday at 2:09 p.m. by Emma. Madison also noticed that the system showed the patient paid $200 cash at 1:53 p.m. and the payment was recorded by Emma. A refund of $200 was then recorded at 2:08 p.m. by Emma. So here's a sequence of the events that happened in the patient's record. We see a $200 payment received, a $200 refund recorded, and then the appointment was canceled. What happened? Shh, you're giving away my secrets. What should Dr. Mike do? Yeah, okay, so we're going to look further into it. Dr. Mike asked Madison to show him the patient's schedule for yesterday. Here's the patient that he saw, and we see that it was a renewal appointment that was canceled. Does this document help? Not really. Dr. Mike then asked Madison if it's possible to see all the payments that were recorded yesterday. So she printed out a daily transaction log from the system. This shows all of the payments, the transactions that happened. And here are the two that are in question. There's a deposit and a refund, and the total was $37.50, which agrees to the deposit ticket. So does this document help? Nope, we don't see anything here. So again, what happened? And what should Dr. Mike do next? Well, just so happens, Dr. Mike has a friend who's a forensic accountant and fraud examiner, and he asked her to see if she could figure out what's been going on. The examiner began by reviewing the daily transaction log. She noticed that there were refunds recorded in the system for a total of $800. Why on earth would there be refunds? You guys don't sell products, people don't come back, they don't bring them back. Why would there be refunds in the system? So then she looked at the patient schedule and noticed the same $800 missing. She matched a payment amount for each appointment and came up with $800 different, $45.50 for the day, but only $37.50 was recorded. So from this evidence, she was able to draw some conclusions. $50 cash is missing from each of these two transactions. The two appointments were changed in the system from initial to renewal, and $50 was refunded to each patient's account trying to conceal the missing cash. The remaining $700 missing cash is from 3 canceled appointments. The 3 appointments were canceled in the schedule, and the payment was refunded to each patient's account to try and conceal the missing cash. In both instances, the patient paid the correct amount, and the refund was recorded after the client left so that the patient received a correct receipt and would never know what happened. The examiner then continued to follow the money. She asked to see the deposit receipt for 4-1 to compare it to the deposit ticket. It didn't exist. She then requested a printout of all bank transactions from 4-1 and 4-2. Here are the bank transactions. We see the overnight deposit of $35.50. The amount showing on the deposit ticket was $37.50. There's $200 missing cash from this transaction. Threw away the receipt, never knew what happened. So the results for 4/1, the total amount received from patients was $45.50. The amount deposited into the operating account was $35.50. There was $1,000 missing cash from that day. No one would have ever noticed except that he remembered to go in and make a note in the patient's account, realized it was canceled. Just by accident, he found that this was going on. The examiner then recommended the scope of the investigation should be expanded back to January 1st of last year to see if there were any other anomalies over the past 15 months. Dr. Mike agreed and forwarded all requested records to the examiner. Here's what she found. The investigation revealed that Emma skimmed $13,150 in cash by changing the appointment types and pocketing the extra cash, $50 at a time. It started out slowly at $50 every few weeks, but by the end of the period, it was up to $500 a week she was taking by changing appointments. During an interview with Emma, the examiner learned that Dr. Bob discovered Emma's scheme in August of last year. He then coerced her into helping him steal as well by threatening to expose her scheme to Dr. Mike, who would, quote, fire her and have her thrown in jail.
Did they at least end up together?
He told her to cancel appointments in the scheduling system so that he could keep the cash for himself. He was responsible for $24,840 in cash larceny. His scheme also started out slowly at $200 a week, and it was up to $1,250 per week by $329. Daniel had also been perpetrating a fraud scheme of skimming cash from the deposits before dropping them into the overnight box at the bank. In his interview with the examiner, he claimed to be completely unaware of the schemes being perpetrated by Emma and Dr. Bob. He also started slowly, but ended up skimming $300 a week by the end for a total of $14,300. So the results of the investigation. Missing cash from canceled appointments and appointments changed from initial to renewal totaled $38,000. Missing cash from the deposits to the bank totaled $14,300 for total missing cash over a 15-month period of $52,300. This is 100% possible. These are, and this is exactly how it happens. With fraud schemes, people start out slowly, they test the system, they do it one time, maybe I just need to borrow some money, but I'll put it back, and then they never do, and they realize no one's watching, so they continue. How could this possibly happen? Even though Dr. Mike had a robust computer system, these fraud schemes were allowed to happen due to a breakdown in internal controls. So let's look at what internal controls are. They're a set of policies, procedures, and mechanisms designed to ensure the accuracy, reliability, and security of a company's financial information. The three internal control issues that allowed the theft in Dr. Mike's practice were a breakdown of protocols, a lack of segregation of duties, and insufficient monitoring and surveillance. So cash handling protocols. So when you're dealing with physical cash, it's a breeding ground for errors and potential misconduct. Secure cash handling protocols need to be in place at each touch point: cash collection, cash counting, and cash depositing. In Dr. Mike's practice, there was a breakdown of protocols at all three touch points. Segregation of duties. This is dividing responsibilities among different individuals to help prevent conflicts of interest, reduce the risk of errors, and create checks and balances within the organization. This can be challenging in small to medium-sized businesses where there's not enough employees to assign different duties. Lack of segregation increases vulnerability to errors and fraud. Lack of segregation of duties allowed Emma to conceal her fraud scheme as well as Dr. Bob's and Daniel's. Emma had the ability to collect cash payments, record the cash payments, issue refunds in the system, which should have never been allowed to happen, and change the patient schedule. Plus, She was the one who created the daily receipts register, which said, here's what we took in today, and counted all the cash and checks received. Nobody double-checked her. Emma also dividing these duties up among different employees would have prevented concealment of the fraudulent act, plus decreased the opportunity to commit the act itself. Daniel was responsible for recording patient revenue in the accounting system, preparing the deposit, and reconciling the bank account. Again, dividing his duties up would have also prevented concealment and decreased opportunity. The person who makes your cash deposit cannot reconcile your bank account. They're just not going to tell you that there was a discrepancy. Insufficient monitoring and surveillance also played a big part in allowing the fraud to happen. Dr. Mike's practice had no monitoring or surveillance. And the difference between monitoring and surveillance, monitoring is somebody's there watching. Surveillance is the eye in the sky. No one monitored the patient's schedule for changes. No one monitored the daily transaction log for irregularities. The refunds should not have occurred. Daniel did not monitor Emma creating the daily cash receipts report and counting the cash. Surveillance cameras would have caught Emma stealing that cash. Since Dr. Mike left each day at 4 p.m. to go fishing, no one monitored Dr. Bob's actions at the end of the day. Surveillance cameras would have caught Emma giving the cash to Dr. Bob. Surveillance cameras would have also captured Dr. Bob's treatment of Emma and their conversations if there was audio recording. State of Florida is a two-party state. Each person has to be aware that the recording is happening and each has to give permission. That can be done during onboarding documents. Oh, I'm sorry, I got ahead of myself. Anyway, monitoring the surveillance helps to deter fraudulent activities, identify irregularities promptly, and maintain secure financial environment. Again, we require recording to be consent for recording. So how do we fix this? This is what we call remediation. Number one, we call the police. Emma and Daniel are guilty of third-degree grand theft. It's a felony offense. That's anywhere between $750 taken, but less than $20,000. It's punishable by up to a $5,000 fine and 5 years in prison. Dr. Bob is guilty of a second-degree grand theft, which is a felony offense. He stole more than $20,000, but less than $100,000. Punishable by up to $10,000 fine and 15 years in prison. After the arrest, terminate all three people. It will be much easier for the police to make an arrest if the employees are unaware that their schemes have been discovered. Number three, correct the books. Record the missing revenue of $52,300 divided between the 2 years appropriately, and record the theft expense of $52,300. Dr. Mike enlisted the help of his friend's qualified medical cannabis accounting firm to help him with this. He already fired Daniel, who's going to make the accounting entries for him, so go to an outside company. Number four, contract the practice's liability insurance company. Check to see if theft is covered under the current policy. It's not usually covered by general liability. It usually requires an employee theft endorsement or rider. I highly recommend you get an employee theft endorsement or rider on your insurance policy. Number five, I think there's insurance people here that can maybe help with that. I don't know. So, number five, issue and file tax documents. Issue 1099s to Emma, Daniel, and Dr. Bob for the amount each took from the practice and for the proper years. This is considered income, and they now owe income tax on it.
That was awesome, that last part.
File the corrected 1096s with the IRS for 2023 and 2024 on all three employees, so the IRS is aware of the additional income that they now owe taxes on. Dr. Mike also enlisted the help of his friend's accounting firm to do that. Number six, inform the remaining employees. Letting everyone know what happened will go a long way to making sure it never happens again. Please don't ever just let these people skulk out without letting everyone know why they're gone. So corrective measures. This is what we do to ensure that the fraud schemes won't happen again. We're going to implement robust internal controls. We're going to put cash handling protocols in place. We're going to segregate employee duties. If your practice is too small that you can't segregate the duties properly, please use an outside accounting firm. They can perform the monthly oversight and the possible day-to-day bookkeeping. Establish monitoring protocols. Make sure somebody watches somebody do things with cash, and install surveillance systems. Seek out the guidance from a qualified fraud examiner who has experience working with medical cannabis practices. If you don't know how to do any of these things, please, please find someone who can help you. I can help you. I don't charge for these kind of services, just to give you guidance. Cultivate a culture of accountability. Effectiveness of internal controls hinges significantly on the individuals tasked with their implementation. Employee training is critical to fostering a culture of accountability and adherence to established protocols. Emphasize the importance of communication. That's the same, see something, say something. Continuous education and ethical conduct. It starts from you down to your employees. If they see you acting in an ethical manner and you communicate to them that you expect them to act in an ethical manner, ethical behavior will commence. So that's pretty much the end of what I had to do to tell you. I have available an ebook. The slide deck is also available to you if you want it. I also prepared a special report for this conference. I was going to exhibit, but ended up not. It's strategic financial planning case study, patient count as a decision-making metric. Florida currently has 880,000 medical cannabis patients. What will happen if Amendment 3 passes, and will your practice survive? Talks about, again, taking the metrics, compiling the data, looking at trends, seeing what's happening in the industry. If you want any of these free materials, there's a QR code, and that's the web address for them. Also, if you liked my talk, or if you didn't like my talk, please rate your experience here and let me know. And if you have any additional questions, that is my contact information. That is my direct line. You can call or text me, and you can email me at that email address as well.
Well done, Peggy.
So just in case you weren't concerned about getting sued, I look at it a little differently. I think the good news for Dr. Mike is his medical practice is much more valuable and much more profitable than he thought it was. So it's good news for him.
He's fun started.
So that's it for the presentation. If there are any questions for anybody.
That's a great question, and we just had handled one of these cases. We've been working on this scenario actually for about, I'd say 18 months, hard. The scenario being, just to reiterate for everybody, that I am no longer carrying malpractice because I don't do what I used to do, a whole lot riskier, let's say, right? Be it your old specialty, right? So I have to have primary insurance because the state of Florida made us set it up this way through the Office of Insurance Regulation. To buy ProMal, you have to have the primary. So what we would do for you, because we don't only sell ProMal, we sell all insurance for physicians and medical practices. We can insure the building all the way to general liability. So we would take you and shop you to the insurance markets as a holistic physician. So then that puts to get a primary that's more affordable. Right. Right. I would have, Peter, why don't you stand up real quick and just kind of go through the, it's kind of that exact math, right?
Give us a quick quote, Peter.
Yeah. So it's like, you're trying to get this down to like, a an affordable rate? Like, give us the quote, Peter. He's the agent. I stopped the mayhem. He's the agent.
Part of it was, can you guys hear me? Part of it was that the state recognizing that cannabinoologists or endocannabinologists exist. It's a specialty that should be accepted. So we've worked with other insurance companies to call you a naturopathic or a holistic doctor, a cannabinologist, and give you the primary coverage. That is, yes, you're correct. You're probably talking between $2,500 and $3,500 for that primary policy, plus our policy, which would give you the cannabis wrongful acts. And right now, everything we've rated in Florida has been really between $1,500 and $1,800. I would, like when cyber came out, you get 4 questions and you get a minimum premium policy. That's how it was once upon a time. That's how we're trying to deliver this product, which is new to the market. Down the road, as more experience occurs, it could get more complicated for people to buy this coverage and more expensive. But right now, the state of Florida is allowing us to pretty much sell it for minimum premium and to cover that cannabis wrongful acts.
Yeah, once we get them comfortable with this in a few, iteration, the first iteration, I think we're going to be combining that, Peter, and just making it one, right? That's our
Correct.
end goal.
That's
right?
our intent.
That's our end goal. We had to, satisfy the powers that be, and we ran a pretty good gauntlet. We think it got it efficient. We would like it to be one, but we can handle both.
Any other questions? Dr. Shaw? Hang on, just 1 second.
This is a question for Dr. H. So I'm from the world of hospice, right? And we have patients that require huge amounts of morphine per day to manage their cancer-related pain, for instance, right? And so for us, we can't say, okay, 10 milligrams, that's it, that's all you can get, right? So my question really is about cannabis and people who have inhalation as their primary or sole means of using cannabis. Is there a limit? Is there some point where we have to reconsider, maybe you should use something else? I had a guy come and say the dispensary told him he should have 800 milligrams per day allowance for his inhalation. And I sat there, I did the math, I'm like, I don't feel comfortable with that, and so obviously I didn't, but do you have any thoughts about how we navigate that?
It's, are we on?
You're right into it, I think.
It's on, okay. So it's like any other medicine, and like we preach about cannabis, it's titrating the dose, and everyone's different of how much it's going to take. I mean, I remember in emergency medicine years ago, I had a severe burn patient, and the amount of IV morphine given over time slowly was, for most people that would have put him to sleep or stopped him breathing, and he was just kept on talking because of the amount of pain he was in. And it's the same thing, with cannabis. There really is no too high a dose unless there's side effects from it. And of course, with hospice, sometimes really near the end, there's nothing wrong in being sedated, because again, it's not going to stop anyone from breathing. And let's face it, sometimes in hospice, that's not necessarily, if people are really suffering, that's not a bad thing either. But the main thing is just titrating the dose until the patient gets adequate relief. And there really is no number that's too high. We don't know in advance what that number is going to be, because of all our metabolisms are different. For one person that could be 100 milligrams, for another that could be 500 or higher, but it's just dependent. But the main thing is titrate, to keep going until we get the desired relief for the patient.
It's funny you said that.
Okay, before you're done, I have a question for you.
Okay.
Well, when you said that, I realized that palliative sedation is one of the things that we offer with hospice. So we will put somebody out if their symptoms are completely unmanaged by any other means. So it's interesting that you made that correlation. But what are your thoughts about concentrates with folks that are dealing with generalized anxiety disorder?
I'm not a big fan of concentrates, to be perfectly honest, just because the dose, I mean, this is for normal for non-hospice patients. not a big fan, just because the dose is so high, it's hard to titrate it to get desired effects without side effects. And you know, as we discussed with anxiety, for some people it really is THC dose related. I mean, you know, I tell my patients, you know, true story. And when I was a teenager, I assumed more would be better, right? I mean, I didn't know any better. And boy, did I feel restless, uneasy, and anxious, maybe even paranoid. Well, now I know why. I've been educated. And that happens to a lot of people. So it's just a matter of, for anxiety, definitely would not recommend concentrates. I mean, unless they have done non-concentrates and find that, you know, they don't have a problem with it and they're getting higher and higher doses with non-concentrated products, and then that's more cost effective for them. But in general, most people, you know, unless they have extreme tolerance, do not need concentrates and really are counterproductive in my personal opinion.
Thank you.
We have a
Thank you very
question
much.
right up
I have a question and a comment. Question, pro-mal insurance, is that a admitted career?
Yes, I'm glad you brought that up. When I said it's been looked at and approved by the Florida Office of Insurance Regulation, that is the definition of what's called admitted coverage, yes. The alternative is E&S, or, you know, you're going outside of the government really saying, or the entity approving it, right? So yeah, it's approved and admitted.
Comment. When you were mentioning about calculating the MME and LME, easiest way to do would be look up patients' E-force profile, which also lists their MME and LME, as well as gives you a NOx score. That's one point. Number two, as we go along, once cannabinoids gets rescheduled to Schedule 3, my gut feeling will be required to look at the patient's E-force profile, because the statutory requirement is when you prescribe any controlled substance, you have to look up their E-force profile before prescribing them.
And in Florida, under the medical cannabis statute, we're still supposed to check E-force. You know, for those of you not from Florida, that's the controlled medicine monitoring program. We're still supposed to check that at every certification visit, whether it's initial or, you know, recertification. So we are supposed to check that every time we certify or recertify a patient.
All right, I have a question for you, Dr. Barton. The quantitative data you're doing on the pre and post effectiveness, is that in your electronic medical records? Because I saw your awesome Excel sheet, but we got to get the EMR, so where are you at on that?
Well, actually, like I say, we're a little solo practice, so we're doing all this manually. We would just enter it. We see it from the chart, and then we take that, we enter it manually into the Excel spreadsheet. Boy, it would be ideal, again, I don't have any commercial product, but that would be ideal for someone to have an EMR where we put the number of their pain score, their anxiety score, or their MMEs in an electronic record, and it automatically pulls it, puts it into an Excel spreadsheet. Certainly for anyone who's an entrepreneur out there, that would be a great project. I'm sure it would be useful.
But be cautious. I've seen 3 lose their bank accounts over this.
All right. Seeing no other questions, do I gavel us closed, Gene? Are we officially?
Gavel is closed. Thank you, panel. All right, thanks everybody. Again, I'll have the proceedings out for the docs that need CMEs. If you want to drop those off at our front desk. If you haven't picked up one of the copies, you can get it at the front desk as well. Thank you, everybody.